وكلية طب جامعة الأزهر دمياط للدعوة الكريمة. My topic will be about the venous ulcer perforator, the culprit. We are always dealing with the superficial and the deep system, but what about the incompetent perforators? To start with, we have a perforator vein and an incompetent perforator vein. The venous system is rich in interconnections. There are around 60 perforator veins in the lower limb. All of them, almost all of them have valves. In presence of chronic venous disease, around 46% are incompetent. Clinically, the presence of incompetent perforator vein is one of the factors that may lead to the progression of the problem of the chronic venous disease. And the relationship of the incompetent perforator veins and the skin ulcers were historically demonstrated and always related to presence of the venous ulcer. But is the incompetent perforator responsible for it? Larger randomized trial, like the Dutch trial, showed that healing rates of around 83% in the surgical group and 73% the compression group, that say that the ulcer has nothing to do or does not improved by the dealing with the incompetent perforator. That to say the incompetent perforator is not the culprit, it's not the enemy. Given this uncertainty, dealing with incompetent perforators is always a challenging task. We don't have much knowledge about the role of incompetent perforator in healing of the venous ulcer. This is patients who are facing in our practice. This is patients have dealt with. They are having venous ulcers, different situations. The second patient, and this is the third one. Before mentioning how to deal with this type of ulcers, just to take a glance about the incompetent perforators or the perforators in general, we have numerous types of perforators through the whole lower limb from the foot to the gluteal region. The most important are the medial perforators of the calf. And this is the duplex scanning showing the perforators, and always seek about the perforator artery adjoining the perforator vein, which is very important on dealing with these incompetent perforators, especially when doing sclerotherapy. Diagnostically, when we deal with these types of varicose veins in presence of large incompetent perforators, it can be palpated clinically through a fascial defect, especially in presence of varicose veins. And the can be best seen by the duplex. We have the incompetent perforators ranging from 2 millimeters to 4 millimeters. These are the significance is shown when there is an incompetence more than 0.3 seconds. This is say the pathological perforator is the perforator that showing a reflux more than 0.35 seconds. Indicators for interruption. That the perforator, the incompetent perforator, is a task or a target for interruption. They maybe have some clues for this, that we could use this we could deal with these incompetent perforators for promotion of ulcer healing, for prevention of ulcer recurrence, and prevention of progression of the disease in C4 extremities. The SBS guidelines for treatment of chronic venous disease mention that any pathological perforator, that's to say, showing a reflux more than 0.5 seconds and a diameter more than 3.5 millimeter adjacent to a venous ulcer, we should treat these pathological perforators. Also, patient with pathological perforators in C4 disease, that's to say just skin change without ulceration, also should be dealt with. And they recommend against treatment of just incompetent perforators in simple varicose veins, so that patient with varicose veins and incompetent perforator without skin change shouldn't be dealt. We should not deal with these perforators at all. The most recent SVS said that in patient with C6, let's say with active ulcer and presence of incompetent superficial system, we have to deal with the pathological perforator. So that when we have a varicose veins patient with incompetent superficial system and incompetent pathological perforator, it should be dealt for, we should deal with both of them. And that to say, we have to ablate the incompetent superficial system and the pathological perforator in the same session, followed by compression therapy. In patients with just skin change and incompetent superficial vein, they mentioned that we could do it in a stage pattern. That to say, we could ablate the superficial system either simultaneously or in a stage pattern. This is different from the active type, that we should deal with both of the incompetent superficial system and the incompetent perforator at the same time. Here, just skin change without ulceration, we could do it in a staged way. A patient with a pathological perforator and the deep system is patent or recanalized, we could deal immediately with the pathological perforator even in absence of evident superficial or incompetent superficial vein. Treatment option for incompetent perforator, that we have a different treatment options. That to say, open surgery and sepsis, and thus become performed less routinely due to the invasive nature and high complication rates. Just interruption of the incompetent perforator can be done by stop avulsion with duplex scanning. But they have they shown that the recurrence rates 32%, and half of them become incompetent. The percutaneous ablation of perforator veins, which is called PAPS, has been the choice, the treatment of choice according to the SVS clinical practice guidelines. For patients with pathological perforator, the ultrasound guided sclerotherapy or endovenous thermal ablation should be dealt with this incompetent perforator, and this is grade 1 evidence. The laser ablation, we have an access to the incompetent perforator through a laser fiber. We should deal with this incompetent perforator just at the fascia level, not below the fascia, after introduction of tumescence. And then the segment can be ablated with 60 to 100 joules. The same with radiofrequency. Although it's a rigid part, we do a compression around 80 to 60 from 80 to 90 millimeter Hg pressure, and we also tumescence is used. The third part, or the third option, is sclerotherapy, and this is for diameters from 4 to 7 millimeters. At the level of the fascia, we can do this sclerotherapy. However, it's the option of thermal ablation is more beneficial. Getting back to our patient, this is the third patient I dealt with. It has got an incompetent, an active ulcer. So what I did for this patient, just for foam sclerotherapy to the surrounding varicosities and the small perforators around the ulcer, because this patient has already done the superficial system ablation, but the ulcer was still persistent. So what is left is the varicosities around the ulcer and the incompetent small perforators. And this was the result. Another patient, patient has a superficial system incompetence plus an incompetent or pathological perforator. So what is done is laser ablation for both of them, for the saphenous and the incompetent perforator, and we have this result. The third patient, this patient has got a post-thrombotic syndrome with recanalized deep system and already ablated superficial system, but still there is some varicoses around the ulcer beside a large incompetent perforator. So what is done is phlebectomies with laser ablation of the incompetent perforator vein. Just 1 minute.
2 minutes more, please.
So what's done for this patient is a phlebectomy to the surrounding large varicoses plus laser ablation to the large incompetent perforator, and this is what the result. Post-operative management, we have to do, the patient should have compression stoking for 24 hours followed by 3 to 5 days compression, or according to the previous condition of the patient, we could have elastic stoking crib bandage and local wound promoters, and follow up by Duplex. This is an algorithm for dealing with the incompetent perforator. And lastly, thank you.
Thank you.